of their age. So this is a dream for India. I would say at least let us achieve this 136 first, and then we move on to the 123. Even in US, the states meeting the 136 have moved on to the 123, and there are still states who are not completed the 136. But I would say that the percentage is 90% of coverage compared to India, which is less than 20%. So when you talk about the technology that we use, we know OAEs are being used by many centers, and we also know AABR is being used. Now you know why OAEs have their own benefits and limitations. I would say it's very quick, non-invasive, effective for initial screening, but definitely cannot detect neural loss. So ANSD is going to be untraceable. Now sensitive to ambient noise. So most of our NICUs or your wards definitely have more noise, ambient noise. So this is definitely not going to fetch a good true positive rating. Next, we have the AABR, where you see that it is more reliable for the high risk infants because it is critical for detecting the ANSDs. Yes, ma'am, we did. We do have a separate room, and we sound treated the room in NICU now, triple N, near the triple N. So definitely a sound treated room is mandatory. As it is next to the triple N, that's again a concern because most of the babies are out crying there. So we prefer that there's a sound treated room and lab which is made. And our NICU lab is at least now sound treated with double door. So we are very happy that we have come to that stage. Yes, ma'am. With high risk, it was the first 2 years, it showed around 19%. Then when we started the well babies, and we had a confirm, everything depends upon the follow-up counseling. So if the follow-up counseling is not done, definitely your referral rate is going to go high. And if the follow-up counseling is effective, our referral rates actually came down to 3.7. So with the UNHS, we saw that it is around 3.7. This is the data from 2020 March to 2024 March. So it's a 4-year data. And pre-UNHS and post-UNHS complaints. So the two-stage AABR protocol is found to filter out around 78% of the false positive cases. So that's why we prefer that AABR be considered in place of OAs. So this is an alarming statistics, isn't it? So you see that there is 22.78 cases per thousand prevalence, and the coverage is only less than 20% in comparison to greater than 90% in a global standard. And the average age of diagnosis in India has come down to 24 to 36 months compared to the 3 to 6 months which is seen in the global scenario. So I would still love to share this with you because we know that there are certain successful centers or programs running across India. So first thing is at AIMS, they started a pilot screening program in 2006. And in 2013, we are all very familiar with the Kerala model, which is the Shruti Tarangam. 2016, Tamil Nadu implemented the district level screening using teleaudiology network connecting primary health centers, where Vidya had taken a lot of efforts through the teleaudiology program. And 2019, the NPTCD included the newborn wearing screening in the guidelines. Still, the implementation remains limited. So I would say it is included, but the implementation is not successful. 2020, PGI, we started a newborn wearing screening program. 2022, UNHS, and 2022, the RDSK planned to include the wearing screening in selected districts nationwide. But despite these advances, the coordination between the programs remains fragmented and the national coverage is still inadequate. So, what are the obstacles that we are facing? One is the logistics of the population scale, right? So, the babies born in India annually, this is an Indian study quoting 24.5 million in 2021. Okay, so we see that 29,000 babies are born daily requiring screening across 718 districts. And audiologists across India, they say 2,500, which is a severe shortage of trained professionals for these many babies. And 58% of these are rural girls. So you can see that we are not covering them. You can easily say that because urban itself is not covering. So obviously rural is definitely not going to cover. So by the numbers, it's a huge number which requires screening daily with limited audiologists and severe urban-rural disparity is seen. So They called this particular centralized their study. Second obstacle, the workforce and infrastructure deficit. There is a specialist shortage, equipment gaps. Even we, being a tertiary care center, it's not easy to say that we have all the equipments. We keep going in for failures in the instruments, and we keep shifting. So recently, the neonatologists decided that they would procure more new instruments because there's a mother child center coming up. So it was a nice point for us to say you can have your own lab there also. So now you start procuring more new instruments. So I was happy to give them specifications. Now we have new instruments in place. But it is definitely not easy for the other centers nationwide because this is a major shortage for equipment. And the rural disparity and the cost barrier. Cost barrier, again, although it is very less, we still haven't accomplished it. So what are the gaps in the system? Like ma'am was asking, the first major gap is the follow-up challenge. So the high loss to follow-up rate, I would say it is around 18.4% as per the study in Indian infants. We had much more when we analyzed our data. And delayed onset hearing loss. This is not going to be taken care of by your, if you don't have a follow-up program, because there can be some progressive cases in later stages. And the first screening inpatient, like in hospital screening is not going to be successful. You have to call them for a follow-up, but not many of us counsel them. We just finish it, send the patient back home. So the counseling part is something which is very important. Need for continuous monitoring. Long-term follow-up is very essential to catch the progressive and late onset cases. So the primary barriers, sir had already said, there is a very limited parental awareness about hearing loss implications. So I keep telling Dr. Praveen, we have the vaccination card, and when every parent is going to be very serious about your vaccination card. At least they are aware about it. So I was telling that we'll have a table there for the UNHS program and say this is your hearing screening schedule. You have to come here for follow-up. So that is when the patients are going to take it more seriously. We're still working on it. So distance and transportation costs. This is a huge reason for centers. Yes, sir. Yes, yes. So the color coding was done, but it was not implemented by the department because of the cost issue there, and they got only the plain vaccination cards. So we couldn't do it, and now they are still working on the color coding. They still haven't done it. So it is a administrative issue where we have all their reasons, but at least it is printed there, and we are counseling them that behind your card it is written. So please come down. But color coding has still not happened. So we're working on it. So inability to take time off work because most of them are daily wages, and cultural stigma regarding disability, lack of coordinated tracking systems between facilities. And the last one is the main one which I have highlighted, inadequate counseling. So I think we professionals are the main reason for it to be blamed because we take that 1 or 2 minutes to counsel them saying how serious it's going to be and what are the consequences. I'm sure every parent will get back to you. So if the counseling is not effective, your long follow-up date is definitely going to be high. You cannot evaluate a program however serious you are about it. So missing follow-up data, the documentation limitations, lack of standardized methods to document and report, incomplete national registries. So national registries often fail to incorporate the diagnostic results. We say first screening is there, second screening is there, but the third diagnostic evaluation is not incorporated. So until you get the final diagnostic evaluation report, you can actually not put your final referral rating of your center. Limited coverage. Most programs exclude the newborns from the private and non-governmental. Like here, we again have the same problem. We are screening all the babies born in PGI, but from outside we not know. So we have to expand the program now from our center. So the pockets of excellence, models of success in India, these are the four which actually I'm glad to say are included PGI Chandigarh model. And the first three, you already know that many people are aware of it. So the fourth one is your Chandigarh. Now, what is the roadmap? I've just suggested a few. I don't know how it's going to be materialized, but then the power of decentralization. So I think it's already worked up in South. Tamil Nadu have already tried doing this. Community health workers, training ASHA workers actually helps a lot in leveraging their established trusted presence for screening. And the personnel, it's a new cadre of mobile vacation. So they are not the professionals, but we are training them for the screening. And the primary care staff, equip them with the relevant instrumentation and the skills to conduct the basic screening. So it is the only viable approach for scaling the hearing screening to reach the 24.5 million for now. We cannot say that you will get more qualified professionals and then we start the programs. It's not going to work out. Second is what are all the issues? Like now in the evidences that you see, as I said, Vidya has already done a study where she has demonstrated community health workers could be trained and they are doing it in their teleaudiology program. Vishwakarma et al. Has documented successful training of 120 ASHAs and basic screening techniques across 4 districts. And the other study showed integration with existing immunization results. So it's something like what I was explaining. And the multi-level screening. So basic screening can be at your village level, the rural area. And finally, the confirmatory test can be done at your agencies. So this approach transforms our population challenge into an advantage by creating a vast network of screeners. So bridging the divide with technology. Again, here we have many studies which has come up with smartphone-based screening apps, teleaudiology, and hub and spoke model. And we have some Indian studies which talks about the smartphone apps. They have developed it. I am not sure how successful it is, although they have given us a data. Evidence-based solutions are there. Digital tracking systems. Sharma et al. 2020 achieved 89% follow-up rates using SMS reminders. Even we tried this. We are still working on it. How we can automatically send the SMS to the patients, the parents, and then they get a reminder. But I would still say the vaccination card works out really much better. Home-based follow-up, as sir said, ASHA home visits increase the follow-up compliance, as per a study by Vishwakarma et al. Incentivized system. So Tamil Nadu model provides transportation stipends which improve the diagnostic follow-up rates. So this is what was done in the state government project where they gave the incentivized incentives for the transportation stipends they were provided and it definitely improved their follow-up rate because they don't have to spend from their pocket. Educational interventions, parental education videos. I think in local languages we don't have many. So in their native languages we have to have parental education videos. And there is a study in Karnataka which has done a good job and it says it has got a compliance of 37%. So this is how I would say integrated registries, SMS systems, continued education and local support is very important for your patients. So this is a public-private partnership which is never thought about. I think we should think about it, where CSR initiatives can be taken. Academic institutions should go ahead with the program evaluation and continue to see what is the negatives of your whole program and then you improvise on it. And no single entity can solve this challenge. The question is that it's not about if we can do this, but how quickly we can scale it is the biggest question. So this is the cost benefit analysis which I was talking about. And a coordinated national strategy can definitely be possible if we work towards it. So I said the first phase can be your high risk screening, second phase can be expanded coverage, and the third you can think about a universal coverage. So you don't have to directly jump onto your universal coverage, it's not going to happen. So are we doing enough? Not yet, but we have the blueprint for success. We have the evidence, we have the models, we have the technology, but we are lacking in the commitment. So we need the commitment to move from isolated excellence to a comprehensive national program. And early intervention is not a luxury. It's a fundamental right that sets the stage for a child's entire life. It is our collective responsibility, all of us as multidisciplinary team, to make this a reality for every child in India. So let's nip it in the bud. Thank you so much again for this opportunity. when they come for their OPD follow-up schedules. So when the parents are made aware at that particular stage, because once the baby is born, the whole process is very overwhelming. So the newborn hearing screening tends to be lost somewhere here and there. So when the nurses train the parents well in advance, they are aware that this test needs to be conducted. Even if the neonatologist or the pediatrician or the audiologist does not reach the parent makes sure that they reach the audiologist for the hearing test. And I think another thing which can be taken into account is the public awareness. What kind of public awareness are we generating? Because parents these days are proactively asking for an ROP screening, a thyroid screening, but hearing screening, nobody is actually aware. Absolutely. So that's what we reduce our cost. Sure, sure. Absolutely. So thankfully, we've managed to achieve that in Max and in other private sector hospitals that we are working in. And I hand over to Dr. D. Good morning to everyone. Thank you. I think with the conclusion of so well. I think in this scenario, my concern would be that armed forces, like Sir said, as it was pioneer in cooperative implant program, it was equally ahead in doing this screening program. As of now, I think it started well in 2010. Special testing was all the hospitals, wherever there is a gynecology or pediatric support, they were given screening for it. And they were given training where they can do it. And if it is passed, it is well and fine. If there is a referral, they used to connect to the next ENT center. So we have 56 ENT centers, and we were all in my time, and I think those who were working under me, they were all given this, and they used to report to me. So in the year to come, what we see that we have had a very robust protocol. We did screening all the children who were born in our hospital. And ma'am said very clearly, what we do, ma'am, that no children who is born in our hospital goes without the discharge is not signed. That is a very bad way of saying, but yes, they are counseled and they are also given this chance to interact with us why it is necessary. So I think we have also had, although we have not scored this thing, we have never been featured in. I think slowly we will have a data because the central registry is being done in Army Hospital. And I think that we are having a good program. In fact, being HOD at two centers, I've already monitored it monthly. And I've seen, as you said, it is almost the same. The high risk group has more, coming to about 15%. And the well maybe is about 4%, 3 to 4%. So very good, excellent talk, and always motivated by the none other than Sir, and very well carried on by very good talk. On the behalf of pediatricians. So we recently got our hospital inspected for an accreditation for baby friendly hospital. So when DK Singh is talking about army, the assessor who said he has probably been an assessor in multiple army units. He says, here, whatever the commander says, everybody knows, every patient is accounted. Whereas here, more than 50% are not accounted. We don't know, they come unsupervised. To have them follow up is extremely. So we were struggling even with the basic thing. When you're talking about hearing, we said breastfeeding is the basic right of a child, and 13% of the deaths can be prevented just with breastfeeding. We still fail in that. When we talk about complementary feeding, we say minimum acceptable diet, 10% only. We have so many failures. You are talking about just hearing. What I feel is that the well baby visit, where all these screening things are required, these have to be integrated. The pediatricians have to be part of it. It is not in isolation. This hearing is all right. But we are losing. As far as when you talk about screen exposures, we have nearly 100% screen exposure. Just 16% of the language delay was just with the every child in the hospital has only one toy. That's a mobile phone. So we are really, really struggling with many of these threats, childhood full development potential. So what I feel is, as a pediatricians, we're talking in isolation. We are really not working for the full development of potential. So really parenting society because they are quiet. Here also I kept few people and I called them that we are going to be just focusing on feeding. And there is a threat because the newborn doesn't speak and the others don't listen. So the advocacy has to be really, really strong. It has to be integrated with all the interventions which are must for a child. So I specifically sat for this because I will now see what is happening in my hospital. Thank you. Thank you for allowing me to. Thanks, Dr. Bhanumati, for such an enriching session, and thanks to our worthy chairpersons for deciding this session. Moving Paris Hospital, Panchkula, and Director Mehak Clinic, Zurich. I request our chairperson to please take their seats in the front row.